Good morning, everyone. Welcome to Surgical Grand Rounds. It's my pleasure today. I'm Mark Molitor, one of the pediatric surgeons. I'm the Associate Program Director for our Pediatric Surgery Fellowship. It's my pleasure to introduce our speaker today. As you know, pediatric surgery every year is proud to graduate one of our fellows. We have a 2-fellowship program. Anthony Ferrantella will be our 7th fellow to graduate from the program. So this is our 7th year of doing these once a year sort of fellowship talks. Tony's from the Midwest originally, growing up in that area that's really cold and gray from what I understand compared to this like bright sunny Arizona things that I'm used to in the process. But Tony did that. He went to school at the University of Indiana or Indiana University Medical School and then to Miami for his general surgery training. For those of you that don't know, ped surgery is actually quite onerous. It's not only the 4 years of medical school, the 5 years of general surgery. Most of us take 1 to 2 years somewhere in there to do a little bit of research. And Tony did that, getting a T32 training grant to do tumor immunology, and then finishing his program at University of Miami. And then 2 more years of pediatric surgery fellowship here in Phoenix. He's been quite productive. He's been one of our go-to fellows. For those of you that don't know, he speaks fluent Spanish, and I thank his wife for that very profusely, because of that, then I don't have to struggle every time I walk into a patient's room, because I know Tony's got it handled. He's done his prerequisites. He's got a litany of publications and all of those things, but I don't think that that's what makes Tony, quite honestly. That is just one piece of him. I like to ask the fellows every year, their question is, why should I pick you as our fellow with things? And the answer Tony gave me 3.5 years ago was, because I do whatever it takes. I will get the job done. If you're not happy with something, let me know, and I will go fix it for you. And I think that that kind of summarizes what Tony has been for us these past 2 years. He has been our go-to guy. He is the guy that we can count on to get the job done. When there is something broken, he will fix it. And so I think that that has summarized his fellowship. He and his wife, Fernanda, have 3 beautiful kids, and I will tell you, I love them because every time they come to my house, it's when can I jump on the trampoline or where's the bounce house? And so it has been great getting to know Tony and his family over these past 2 years. We will very proudly send him off to Children's in Atlanta, where he will begin the next phase of his life and career, and we wish him all the best. Today, Tony is going to speak with us about rotational anomalies. And so, Tony, please fix this problem for us and let us know what we can do. Tony Ferrantella.
Okay. All right. Well, Dr. Molitor, thank you for the introduction, and thanks for the invitation to talk with you all today. All right. I don't have any disclosures to tell you about, unfortunately. So for those who might not be familiar with the terminology, intestinal rotation anomalies encompass sort of a wide variety of anatomical variants that result from differences in the way the intestines rotate in the growing fetus. Most commonly, we think of malrotation, but these also include the abnormalities that occur with defects of the abdominal wall, gastroschisis, omphalocele, as well as heterotaxy associated with cardiac defects. So kind of all these differences that we find are kind of more commonly used, this blanket term of intestinal rotation anomalies that kind of encompass all of these, and they all kind of share some commonalities that can become problems for children. So to understand these variations, it's important to kind of go back to medical school and kind of think about what happens during embryology here when, during the early gestation, the primitive bowel, it herniates through the umbilical cord and it rotates counterclockwise around the axis of the superior mesenteric artery. And by the 10th week of gestation, the bowel re-enters the abdominal cavity and it completes its rotation, with the duodenum passing posterior to the superior mesenteric artery. And it's important that this fixation point kind of defines normal anatomy for the radiologist, who, when they're performing an upper GI, will be looking at this portion of the duodenum to see that it goes retroperitoneal, showing that it goes behind that SMA. And that on the lateral views, the anterior views rather, that it actually, that on the lateral, that it goes posterior, and that on the anterior view that it actually crosses all the way to the left side of the spine and comes back up to the level of the pylorus, signifying that the rotation of that axis is actually completed. So that kind of defines the ligament detritus, and then the remainder of the small bowel and the colon then rotate anterior to the SMA. They come back into the abdomen and undergo further fixation to the retroperitoneum along the length of the ascending and descending colon, thereby kind of stabilizing the gut. As depicted here, the small bowel's blood supply becomes part of sort of a broad mesentery, and that extends from the left upper quadrant to the right lower quadrant. And these are two main points of fixation for the bowel, most specifically the ligament detritus, and then the retroperitoneal attachments to the right and to the left colon, which ultimately stabilize the intestines and prevent a catastrophic volvulus from occurring in a child that is, or person that's fully rotated. So when the process fails to occur normally, the intestines migrate into a configuration that is commonly referred to as malrotation, where instead of having a broad, wide-based mesentery that fixes these two distant locations, those being the ligament detritus and the cecum, we instead have these 2 points of fixation that are very close to each other. And this is a problem because it leaves the midgut predisposed to volvulizing around a very narrow mesentery. And with that, of course, can result with ischemia and eventual loss of intestine. But the problem with this terminology is that rotational status is not exactly binary. It's not just either you're normally rotated or you're malrotated. It truly is sort of a spectrum of abnormalities. It occurs when any part of this whole process either is incomplete, arrests, or occurs just out of order. In the various configurations that occur as a result have been characterized as these depictions show here. So in addition to what's classically thought of as normal, or I should say malrotation, there's also what's been referred to as a typical rotation, where perhaps the ligament of detritus is low-lying and doesn't fully migrate all the way up to the left upper quadrant. There can also be non-rotation, where the developing bowel and colon fail to really rotate at all around the SMA as they re-enter the abdomen. And they kind of sit in this configuration where the small bowel's on the right and the colon is in the left. And we'll kind of come back to that a little bit later when we talk about how we do the LAD procedure. And then quite rarely is reverse rotation, which the colon will actually enter the abdomen prior to the small bowel. And so then you have the colon posterior to the small bowel in its mesentery and the small bowel anterior. And this has been documented, but is really, really uncommon. However, all of these configurations that are not completely normal result in a narrowed mesenteric pedicle that's at risk for twisting around itself. So now that we've kind of defined what the spectrum of these anomalies are that constitute malrotation, how common is it and how is it identified? The true incidence is unknown because some people with malrotation may go their entire lifespan without ever becoming symptomatic. And so in those people, those individuals, they might not ever be diagnosed. So it's really hard to know what the true incidence of malrotation is. But some older autopsy studies have suggested that it may be around 0.5%, given that it was found in 1 in 200 people for which autopsies have been performed. However, symptomatic malrotation in neonates is a little bit better understood, and it's been estimated to be about 1 in every 6,000 live births. And volvulus is then estimated to occur in about 1 out of every 30 of those neonates that has malrotation. The majority of volvulus events occur within the first year of life, estimated to be about 70% based on pretty good data. And the majority of those, more than 50%, will actually occur within the first month of life, so that we know it's really the newborns and early neonates who are by far at the highest risk of this occurring. And it really becomes quite rare as kids grow older, and to the point where it's extremely uncommon in adolescents or adults that have malrotation to, at that point in their life, present with an acute volvulus. And so how do these babies present when they, when we suspect they have volvulus? Well, we all kind of know bilious emesis, right? It's like what we're all kind of drilled into us that when there's bilious emesis, we have to suspect malrotation with volvulus until proven otherwise. There have been surveys to sort of characterize what medical providers as well as patients or parents of infants believe to be bilious emesis. And using these color tiles, sort of like you would get at a hardware store when picking out paint to pick a color for your child's nursery. They use these like, yeah, right. They use these like little tiles to survey both medical providers, including, doctors, neonatologists, surgeons, bedside nurses, as well as the parents and say, what do you consider to be bilious emesis? And what was pretty clear from these surveys is that there was no consensus. Nobody really agreed upon what it is. Some people say, oh, well, if it's dark green, it's just not digested yet. If it's yellow, that means that it's partially been digested. But ultimately, there's not really a clear consensus, which really highlights the importance of kind of asking about this situation like in a very open-ended manner and saying just, what did the emesis look like? And can you tell me what color it seemed like to you whenever you're either talking to the parents in the ER or whether you're talking to perhaps, the other personnel in the hospital that were at bedside when it occurred? And we really shouldn't be leading with, was it bilious? Because what might be considered bilious to one person may not really be thought of as being bilious by another.
Is there a consensus among surgeons?
There's not, no. And so kind of to that point, and in general, as was once told to me that the best rule of thumb is, if it's green or yellow, call the surgery fellow because you should probably be getting a surgical consult at that point. And the first thing that we're going to ask for as we're on our way over to see the patient is to go ahead and get a stat abdominal ultrasound. And, when we look at this, the ultrasounds, there's actually really strong evidence to support that at large experienced pediatric centers like ours, we can reliably and quickly identify malrotation and more importantly, volvulus with the use of ultrasound. However, historically, and in many hospitals across the US and throughout the world, upper GI remains the gold standard for diagnosing malrotation. But as you know, upper GI is a bit cumbersome. It requires, the radiologist to be present and transporting the patient down to a fluoro suite. And it also has its own technical challenges that also make it sort of user dependent based on who's doing it and their experience with doing it. But in our hospital, as highlighted in this recent publication by Dr. Yusufi and Dr. Goncalves here at Phoenix Children's, we find ultrasound to be really reliable for this purpose. And what we look for when we're assessing for malrotation on ultrasound is the orientation of the SMA and the SMV when we're looking on kind of this axial image. In a normally rotated child, the superior mesenteric vein should be located to the right of the superior mesenteric artery. And in a malrotated child, the orientation of those vessels is reversed. And often it's found to be just sort of stacked, signifying that that rotation arrested early, but never fully completed so that you have the vein over on the right side. Additionally, we can see on the ultrasound is the position of the third portion of the duodenum. So we can actually see, like you see here on the panel on the left side of the screen that's reported as normal, you can see that bowel going underneath those vessels that have those big arrowheads pointing to them. And you actually see bowel signature going over the aorta behind those vessels and crossing over the spine as it's making its way across the midline and going up towards the ligament of Treitz. On the other panel, you see that there's you see that there not only are the vessels flipped, but there's an absence of anything going behind those vessels and over the aorta. Additionally, that is a really helpful finding is the position of the duodenum, and it kind of helps us assess even in the absence of whether or not there's a volvulus, kind of what the rotational status is. And so all of these findings, they get reported when you look at the ultrasound reports on our ultrasounds that are done here. There's actually a section that specifically reports the relationship of the SMA, SMV, and D3, or that third portion of the duodenum. And it's really helpful. So in the case of volvulus, the SMA and SMV can be followed along their axis with the ultrasound probe and using, real-time flow. We can see that there'll be like an abrupt cutoff as kind of demonstrated here. And that signifies that there's, a volvulus with actual ischemia and a disruption of the blood flow going down the SMA. But even in the absence of a complete ischemic event, if there's volvulus, there's still secondary signs that you can capture on the ultrasound. And so kind of shown here in panel A, you can see a big distended collateral vein that's not along the axis of the SMA and SMB, suggesting that there's venous congestion. And then in panel C, you can see kind of this, what's referred to as the whirlpool sign, where the mesentery is kind of wrapping around the axis of the SMA, and the bowel is also kind of wrapped around there. We find this to be really, really helpful, really quick, and with skilled ultrasonographers, we get really, really good information from this study. However, there's limitations, and if we can't really get adequate acoustic windows in the patient to be able to see this area, most commonly because there might be distended bowel, and that bowel, which is air-filled, doesn't allow us to actually penetrate with the ultrasound and see it. Then we're kind of left having to revert to doing an upper GI series to really kind of assess further. So in these instances where we're doing the upper GI, if we still have adequate concern and we're going that direction, there's a few examples of some abnormal studies. So the first one that's on that says panel A there is labeled as inconclusive. At first glance, it actually looks pretty normal, because the duodenum, it has a really nice C loop. It crosses midline. It kind of goes up towards where you would expect to find the ligament of Treitz. But if you look really closely, you'll notice that this ligament of Treitz here, where the bowel ends, it does not cross all the way beyond the left border of the spine, which is what we would expect in a fully rotated child. Additionally, we would expect it to come all the way up to the level of the pylorus. But there's also technical limitations with doing these studies. So you can see here, the stomach is fairly distended here. And with a distended stomach, that distension can actually push the bowel sort of downward. And it's very possible that this is actually a normally rotated kid that just has a distended stomach pushing down, or it could be an incompletely rotated kid, and which is why this is reported as inconclusive on this particular study. Then the other panel shows here malrotation without a volvulus. And here you can see that there is a very incomplete C loop to the duodenum. It never crosses over the spine, and all of the small bowel is on the right side of the abdomen, very consistent with a malrotated status. I say malrotated, but really you can make the argument that this is also, non-rotated. So you can see how the terminology can be kind of ambiguous depending on what you're seeing, and why, using a term like in rotational anomalies really kind of is better at encompassing these things, because it's not always clear. In these additional GIC or upper GI series, you can see that these are consistent with malrotation as well as with volvulus. So you have on the left panel sort of this corkscrew appearance where some contrast is kind of trickling through, but obviously it's narrowed and you see evidence of twist from that corkscrew. And in the other panel, you see just a abrupt cutoff, sort of a beak appearance, and an abrupt cutoff signifying that the contrast doesn't go beyond that at all, suggesting that it's volvulized at that point. So when we have these findings of volvulus, the next step is to proceed emergently to the operating room, as we all know, where we explore, we promptly detorse the bowel, and perform a Ladd procedure. The Ladd procedure was described nearly 100 years ago by William Ladd, who is an American surgeon. He was surgeon chief at Boston Children's Hospital, and is considered by many to be sort of the founder of the discipline of pediatric surgery, because he was the first surgeon who really dedicated his entire clinical practice to the service and treatment of surgical care in children only. And he initially had a series of like 10 patients in 1932 where he described, emergently doing a laparotomy and just detorsing the bowel. And then with experience, he kind of gained more patients. And in 1936 presented a series of 21 patients where he describes what we, really commonly now think of as the Ladd procedure. And it continues to bear his name. And we continue to do it in more or less the same fashion. And so what that procedure entails is, quickly detorsing the bowel to kind of reestablish blood flow, and then lysing these congenital bands that are causing the constriction, which are commonly referred to as the Ladd's bands, which are these kind of fibrous attachments between the right colon and cecum to the duodenum, liver, gallbladder, kind of everything in the right upper quadrant, I should say. And then going on to sort of widen the mesentery and by placing the colon on the left side of the abdomen and the small bowel on the right side and straightening out any tortuosity of the duodenum so that there's not kinking there. And then lastly, performing an appendectomy. So you can see here that nearly 100 years later, we're really doing the same procedure. Now, more often we're employing laparoscopy and minimally invasive techniques, but essentially doing the same thing. And then less and less commonly, we're performing appendectomy. Historically, the reason for removing the appendix was that it's now in an abnormal location, and it may not be, readily identified, that a child's presenting with acute appendicitis, and when you're going on clinical exam alone. But with modern, imaging modalities, we're very good at capturing appendicitis kind of regardless of where the appendix resides. And so it's kind of a little bit starting to fall out of favor, the practice of just prophylactically removing the appendix at the time of a LAD procedure. So you'll see here on the final panel there that this looks a lot, they're really identical to what we showed previously as being a non-rotated status. Ultimately, we've derotated that whole process of the bowel rotating around the SMA, and we have all the colon on the left side, all the small bowel on the right side, and that's kind of the best we can do to really splay out that mesentery and make it as broad as possible. There's not an effort to try and recreate what is expected to happen for normal rotation. That's just not feasible, and it's probably not safe. It'd probably leave the patient at higher risk of volvulus. So this is kind of what we aim to achieve, and this is now going on for almost a century as being kind of the standard of care. And then the important thing to recognize is that even after having performed a LAD procedure, this does reduce the risk of volvulus, but that risk is certainly not zero. These patients are still at elevated risk compared to normal population or a normally rotated person. They still have some elevated baseline risk, we think, of going on to have a volvulus at some point in their life. But it's dramatic. We believe that's dramatically reduced by having performed this procedure. Here's a couple of operative images. These kind of highlight just how narrow that mesenteric pedicle can be. And you can just kind of imagine here on the left side how easy it is for all of that small bowel to twist around that very, very narrow mesentery, which is abnormal. And then on the right side, those are some example of like LADS bands where we have these kind of abnormal fibrous attachments from the colon to the duodenum and the liver there, causing that sort of constriction and kinking there. Now, for patients that don't really present in sort of a urgent fashion, that aren't kind of this baby that presents with bilious emesis or kind of having extremis with abdominal tenderness and kind of concern for ischemia, the findings or the symptoms can be pretty subtle in a patient that has symptomatic malrotation. In a baby, this may just actually be poor feeding, which is why frequently we're requesting, as surgeons, to get these ultrasounds and studies done on babies that we're working up for placement of a G-tube, because, they're not just really crushing it. They're struggling with feeds. They're having intermittent emesis. They're not tolerating bolus feeds. And we want to know, is it possible that they have some component of malrotation, given that it's relatively common? And could that be contributing to their feeding intolerance? And do we need to address that at the time of placing a feeding tube, or potentially even just address that and see if their feeding issues improve? And then in older children, there's frequently kind of this like vague history of intermittent abdominal pain, like nausea, bloating. Sometimes they kind of self-regulate, have these episodes where they kind of get bloated, they don't eat for a day or so, and then their symptoms kind of get better or self-resolve. And then in some instances, even constipation. And, these symptoms can sometimes go on for weeks or months, and it's, not really as striking as that newborn that presents with bilious emesis. And sometimes these are kind of diagnosed much later, and they kind of have already gone under a pretty extensive workup until some sort of cross-sectional imaging is done that ultimately identifies that they have malrotation. And then now, becoming increasingly common is the incidental finding of malrotation on the patient, the kid that comes in after being in a motor vehicle crash and gets a CT scan and doesn't have any real, solid or hollow viscous injury, but is found incidentally to have malrotation or got some other imaging done for some other purpose. and are now found to have malrotation, but their entire life have been asymptomatic. And then what do we do for this kid? You know, how do we counsel the parents for them? So, in these older kids, shared decision-making really needs to take place regarding the indications for surgery and the potential for postoperative complications and kind of what is the outcome that we're aiming for. So typically in these older patients that don't have symptoms, we believe them to be at lower risk of volvulus, knowing that the overwhelming majority of volvulus events, about 70% of them occur within that first year of life. And as kids get older, it's less and less common. We know that, it's kind of diminishing gains when we're thinking about offering this procedure. Now, with laparoscopic techniques and minimally invasive techniques, we know we have kind of less morbidity, but it's not infrequent that even in initiating a laparoscopic procedure to perform a LAD or to correct malrotation, that there's some aspect that can be challenging or unsafe to complete laparoscopically, and you have to convert to an open procedure to safely complete the procedure. And we have good studies and good data and good follow-up to know that, the incidence of postoperative adhesive bowel obstruction after an open LAD procedure is pretty significant. Long-term studies have shown that it's somewhere in the ballpark of like 10 to 14% in the long term, which is, not inconsequential, especially when you're, counseling the family of a school-aged or teenage child who is incidentally found to have malrotation. And so that's kind of raised the question of, should we really just be counseling them for watchful waiting, which, we'll kind of get back to that, but is in select patients kind of becoming the pathway for them. It's also important to recognize that certain congenital diagnoses, also include intestinal rotation and anomalies as part of the constellation of their findings, and that these may also not really require a LAD procedure if the patient is asymptomatic. So these commonly include abdominal wall defects such as gastroschisis and omphalocele, where the bowel is, outside the abdomen at birth and is clearly not fixed to the retroperitoneum. And these patients are all by definition malrotated because they don't have these normal retroperitoneal attachments. And then there also includes other disorders of intestinal fixation, such as congenital diaphragmatic hernia. They show here where the intestines are all up into the left upper chest and herniated through the diaphragm. And clearly, during gestation, those babies do not have normal fixation of their organs as we, reduce them all into the abdomen at the time of birth. Or when we operate them in the neonatal periods, the question is, should we be performing sort of a prophylactic LAD procedure at the same time? And historically, that was more commonly done. But now it seems like there's kind of good evidence that, maybe we shouldn't just be automatically doing that, and that maybe, these patients are not as high risk as other patients with malrotation, and that, to do less is more in the neonatal period for these patients. Now, one other diagnosis is prune belly syndrome, also known to have abnormal intestinal fixation, and typically those patients are also found to have some component of malrotation. And those patients are also undergoing, other procedures where, they're going to be going into the abdomen anyway for whether it be urologic procedures or abdominoplasties or, feeding access. And the question again comes up, like, should we be pursuing LAD procedure at the same time as those other procedures? And again, kind of the consensus is that in the asymptomatic patient, you should just leave that alone, but we should, educate the parents, and that we all need to be conscientious that when a patient carries this diagnosis and then presents at another time with any, abdominal complaint, we really have to maintain a high index of suspicion that they could have some sort of segmental volvulus occurring, and we need to evaluate for that. Let's see, advance. Similarly, in patients with congenital heart disease and heterotaxy syndrome, these kids are also pretty prone to errors in intestinal rotation. And this type of malrotation is often referred to as a typical rotation, but we have all these kind of weird things that can occur, situs inversus, and non-rotation, reverse rotation. And these kids are commonly getting some sort of imaging performed to evaluate if they have asplenia or polysplenia. And at that time, we're also assessing, but at least here assessing to see do they have evidence of malrotation. And in the past, this was, I think, more frequently intervened on. But it's been shown that in these patients with heterotaxy, they're at quite elevated risk of perioperative mortality related to the underlying cardiac disease in trying to sort of tackle these problems, and that their rates of volvulus are actually comparatively lower or somewhat less of a risk to them than sort of the peri-op events that can occur by putting these kind of delicate cardiac patients under general anesthesia for a sort of semi-elective procedure. So for this reason, watchful waiting has sort of become the recommendation for these patients. And this practice has been supported by work done here at Phoenix Children's by Dr. Van Leeuwen, among others, where they've kind of outlined this algorithm for screening as well as managing rotational anomalies in infants with heterotaxy. And the emphasis has really been placed on watchful waiting and educating the parents and educating providers for these kids that have heterotaxy. And, educating them that if they go on to become symptomatic, then yes, we need to reevaluate and we need to potentially do something about it. But like just the fact that we're finding this in the neonatal period doesn't mean that we need to be offering some sort of early intervention that they may never need, especially because it's thought that kids with heterotaxy are somewhat lower risk of actually having volvulus compared to other children with like classic malrotation. So kind of to summarize, the key components of the modern paradigm for the workup and the management of intestinal rotation anomalies includes utilizing ultrasound as the first line diagnostic tool and employing minimally invasive laparoscopic techniques to minimize surgical complications, as well as the postoperative morbidity of an open procedure, and placing an emphasis on an individualized approach for each child with watchful waiting for those children that truly have asymptomatic malrotation. And that's it. So thank you for your attention. Thanks for the invitation to present. I'd like to acknowledge Dr. Van Leeuwen as well as Dr. Notrika, who helped me out by providing some of the images that you saw here in the slides today, as well as thank our entire group here, all the surgeons that have committed tremendously to my training here, which has been a wonderful experience. This is a picture from my first month of fellowship when I got to do a Kasai procedure with Dr. Notrika and Dr. Lee, my mentor. And then there's a picture from Halloween with some of our amazing APP team who have taught me just as much, if not more, than the surgeons in the room today. So thanks. Yes.
Yeah, I can show that with me. What would be the next step?
So yeah, the next step sometimes is to bring them back for another image or to, place it. It's tough because once you put this contrast in there, that contrast hangs out. So it's not like you can just drop an OG tube and suction out and all of a sudden kind of start fresh. It does become a real challenge. So if, the kid has other clinical worrisome signs, then you talk to the family about potentially just doing a diagnostic laparoscopy, a very low morbidity procedure in a kid that's of acceptable, anesthetic risk, and say, look, we couldn't rule it out. This baby has bilious emesis. The stakes are high. We think that we should just, put in a little camera, make an incision, and take a look around. It goes without saying, a kid that presents in extremis or something, we sometimes forego any imaging at all. If the suspicion's high enough, we might not even get an ultrasound or an upper GI. We may take them directly to the operating room if they look sick enough and say that, look, our operation is diagnostic because, we're worried enough that this kid has something terrible going on. And then in other kids that, otherwise it was like maybe done for some other indication, they weren't having feeding intolerance, they weren't having bilious emesis. Typically, we would just repeat it like in the coming days, or if it's, an outpatient procedure, maybe in a few weeks or something. Dr. Egan.
All right, thanks for your presentation. Can you comment on, or just kind of review what the procedure is in the ED here for child who's found to have volvulus?
Yeah, definitely. So, I think our ED does a great job. We get contacted early on these patients. The suspicion for volvulus is there, and like let's say a young baby or newborn comes in with bilious emesis often, which is the right thing, is we're getting a phone call as the surgical consultants even before an ultrasound's being performed, but as it's being ordered. And then when ultrasonographers are identifying volvulus, they are immediately calling the attending radiologist when they suspect that they're seeing it on ultrasound at the bedside. And they're immediately, making a direct phone call to the attending radiologist to say, hey, I'm doing this ultrasound on this kid. It looks like a volvulus. And that attending radiologist is then immediately alerting the often the ER as well as the surgeons on call. Yeah, and I think we do a fairly good job of that. I mean, we, and our OR, teams, they understand and they move things around when these patients present, and they get the patient upstairs right away.
Can you comment on what's of all kids evaluated in 2024, what percentage are actually getting to the OR and having it fixed without any malrotation? Maybe your colleagues here can comment on what it was 20 years ago. Because I mean, I remember one of the first kids I had on the ward for central line sepsis and all, they had a shortcut. It was at a local hospital. And between his first episode of bilious emesis and when he went to the OR, it was probably 12 hours. And he lost most of his small bowel. And so I'm guessing that happens a lot less nowadays. But I'm guessing it still happens some. And I was just curious if anybody knows the statistics of how often is the surgeon saving the day in time versus saving the day, but a little bit too late?
Yeah, I mean, I could tell you my limited experience here over the past 2 years. Yeah, it is pretty uncommon, especially in a baby, to be presenting a midgut volvulus and have, all dead small bowel that has to come out. I feel like most of the ones we've done, we've been able to detour and salvage bowel. Not all of them, though. There have been, young babies that have lost bowel. More commonly, we're seeing volvulus where we have dead gut and which I didn't really touch on this, but not necessarily in malrotated kids, but kids that have these gastrojejunectomy tubes. And we do think that there are times where that distal aspect of the feeding tube kind of acts as a lead point and they volvulize around that. And it's typically in like delayed children that can't communicate well, that have other barriers that, we're seeing those kids with pretty late presentations and having to at times remove a large portion of bowel. Yes.
Can you have numbers? Because and it's kind of something I advocate.
Yeah.
There might be.
I don't know off the top of my head to be able to tell you, I can tell you, anecdotally in the past 2 years, I mean, we've taken care of, I don't know, maybe 4 or 5 patients that have had that occur, which is scary. But there are a lot of other kids out there with GJ tubes that, aren't, running to the ER with this problem. But it often brings up this question as, what's the right thing for these kids? Should they have gotten consideration for like a Nissen fundoplication or an anti-reflux procedure to circumvent the potential risk of that occurring? But that's kind of a loaded question and a conversation that has to really involve the family as well as the other doctors that are taking care of the child, kind of on the long-term basis.
Where most experienced surgeons seem magically decreased over the last 20 years, and volvulus that does not have unified bowel.
Yes, I think the last time I saw a actual necrosis from a bolus was in fellowship.
Okay.
So I haven't seen it since then, but like Tony said, there's kids that are normally rotated that sometimes come in with a segmental volvuli, and those are harder to pick up. And sort of that like later diagnostic. Those have segmental necrosis.
The first time I saw it here was 19 years ago now. This is my 20th year, and it was a 4-year-old who we sent home with constipation. And she came back in with midgut volvulus and dead bowel. And she just graduated from college, and she's in nursing school. She's going to be a nurse. But it led me to study this for the last 2 decades. And the idea that your 4-year-old could come in and you didn't know, how do we decide who needs an upper GI? And Craig remembers this story probably. My daughter had ileus emesis. She was 4. I told my mom bring her in now. And I don't know if you guys remember Dr. Banks. Yeah, so he thought I was crazy, and Mustafa did a ultrasound, one of these dynamic ultrasounds where we watched Kara drink and have it go underneath in the duodenum. And he was very kind to me, but he's like, yeah, you're a little over the top here, thinking your daughter has globulus. And then like 2 weeks later, Craig, you remember he called us and he said, you're not going to believe this. My son has malrotation and you and Craig are going to do a lot of procedure on him. That's a lot of personal health information, but he's not. I just think you have to really think about this problem as a lifelong problem, for all these kids. And so anybody who has malrotation, you're never fixing it. You're really at some point just maybe reducing the risk. And then any of your kids at home, anything bilious, sorry, they need a study. So that's kind of, dramatic, but changes what you study.
First year gross anatomy, we had a geriatric cadaver that had malrotation discovered on.
Right.
So I can't tell you what such situation. I'm impressed with either August, they're really great or producing really great. So I got to see one. I've seen dead valve. I was like a year ago, I was in Dallas. And it happens. And we miss it. It's oftentimes these brain newborn babies. I know if you've got a big duck in the room for anybody, if we see bile come out of the G tube, if anybody says yellow, whatever, we don't ask it. We don't collect $200. Like, I don't even want to talk about anything else until you tell me what you look at how the ultrasound or how the GI shows, and I'll be able to see the baby volume bring that. And so I think there's heightened vigilance, and pediatric surgeons are kind of like, in this context, it's one of the few truly surgical emergencies that we have in our field. This is the baby that I carry. I did this 2 years ago. I carry the baby from the ER to the OR myself. I don't care what paperwork needs to be done. I don't care what, get the baby in the operating. And so I think it's good to keep having vigilance, and Greg, kudos to you. If you've got a aura that you're not seeing.
Even on New York Hospital, Starling, when it finally opens, don't get me started. It will have a 60-bed NICU, right? And all of our services, all of our emergency services at that hospital are set up around, but if I have to do a volvulus at 1 a.m., the answer is yes. We will get it, we'll be able to diagnose it. We have all the radiology stuff. We can either, transfer that kid's stat and meet him here in the OR, or one of us will go out there and do it. So it is the number one thing that, like, to the timing of it is so important.
I know it's red flashing lights.
Yes.
The thing I heard as a resident, my grandma back then, that he said it's about the only thing that will get me out of bed at 2 o'clock in the morning and the door at 3. Meaning not put your gas or anything else, but maybe a thought. And then last question, how often, we had a recent case of a kid that was discovered on exploratory lab to have a malrotation, but the ultrasound had been read as negative, and I can't remember blanking whether they let them know. I think they received enough of the GI that was not as possible. So talk a little bit about the kids that have malrotation, but the imaging, at least the first imaging studies do not show it, and that's it's a non-valualized malrotation. But any surgeon in the audience can, you don't have to be there.
It's a huge problem. They will tell you they're not gold standard. We think upper GI is a gold standard for malro, and it's not. So how do you hear you?
Yeah, I was just gonna say that, from all these situations, I think that it's really important for surgeon to get bedside with the radiologist during the studies, whether that's the ultrasound, upper GI, both, eventually looking at them together, interpreting them together, looking at the patient at the same time, saying, well, even if they don't see an obvious malrotation or obvious volvulus in either of these studies, the patient is very, really instructed, is having really services and maybe it's even said, we're going to look up for anyway, or this is what we see, that's why we're finished work. So sort of constantly have that conversation. Basis, make sure that you're seeing what you're seeing.
One of the things you showed there, Tony, Jason, for your concerns here is that, that one stomach was big, right? Which we didn't know. It's really important thing because the battery's full, the bowel is full, right? And so you can theoretically have malrotated travel. The test was flopped in the right spot and it looks like it. That's why ultrasounds and GIs are, not perfect. They're 95% sensitive. Patients, but they're not perfect. Get the bowel dynamic process. And just back extension, there's all three. Put things in a way that's looking from what we're looking at. Except a picture of the most important thing. I had that quarter twist. Was that's a hypermutation anomaly. Twist. This is
Seco, maybe had been outside thinking. Shot contrast and Seco was in the right quadrant. It's normal. That is a normal period. That's true. Seeing that big dive in the valve and seeing the right quadrant. That's a malrotation. So it's subtle sometimes. The easy ones are easy, the hard ones are harder. And I think that's sort of it. There are some things that shouldn't get studies. That should get information. Maybe to say,
Obviously, that should accept jump surface. So, there are things that your general surface on. Yeah, very clearly authorized, very sick operation. And by the time they they, as far as I know, they're worse than your general service. Service.
I think we're gonna ask something.
Thank you for, mentioning that the risk doesn't go away
Yeah.
after surgery. And that we tell the parents, always be on the lookout for this, and for them to, when they get to the ED, triage desk at the very front door of the ED, they say the word malrotation and possible prognosis, and that'll get them in right away, so that they can have the child be evaluated, even though they've already had it.
that came back after a line.
All right, thank you.
Okay.